Good morning, everybody. I'm Federico Piramide. I'm a neurologist at San Luigi Hospital in Turin, Italy. It's a pleasure to moderate this session, and I would like to introduce Niki Rashidian, hepatobiliary and pancreatic surgeon, professor of computer-assisted surgery at Ghent University, that will talk to us about from metrics to meaning, contextual learning as the next frontiers in surgical education. Please.
Thank you so much for the kind introduction, and thanks to the Vattikuti Foundation for the kind invitation. It's a great honor to be here today among all these pioneers in robotic surgery, as well as master educators, all beautiful talks that we have been hearing today. These are my disclosure. I'm a director of research and skill development at ORSI Academy, and I'm also a consultant and an advisory board for several medtech companies, but I do not have any financial conflict of interest in this presentation. And maybe one personal disclosure, I will be today talking about the contextual learning and what is missing in our metrics, and specifically on AI assessment for surgical education. One important point to mention before I start my talk, I have been doing research on using AI and surgical education for almost more than 10 years. And if the context of this presentation sounds a bit negative toward AI, it doesn't mean that I don't believe it, but I just want to, all of us, be mindful and be actually knowing the fact that exists nowadays and where we have to go toward. So just like all of you, I also believe that AI is here to stay, and AI is here to be our actually best help for surgical education, but we have to be just careful that what do we have at hand. So I think we all would agree that surgical education is a complex skill, and for learning the complex skill, we need a set of skills which is cognitive, psychomotor, and non-technical skills. As much as all these skills are important, specifically non-technical skills, we heard a beautiful talk from Nicholas this morning about this. It's not that we should put that aside, that's absolutely important, but the focus of this talk specifically is on psychomotor training, not the other ones. So we heard about the challenge of surgical training, about the robotic surgery training. We know that robotic surgery training is intimidating, and that's for a good reason. We do have this complex technology in hand, and the dynamic is different from open surgery, from laparoscopy. And we also all agree that human body is no longer a training model that we can use, and we have to be looking for other ways of training, and a lot of research has been gone to this area from the very beginning of robotic surgery. In the beginning, when, well, at least I think still in a lot of context, it's the reality that most of the time we ask our residents, have you done this procedure before? But actually the question should change. We are not looking, have you done this before? We are looking to ask the question, can you do this safely, consistently, and also toward the defined standard that we do have. And that's where the proficiency-based training comes into place, that there is a huge body of evidence showing that proficiency-based training is actually effective. We can reduce the errors by training people to proficiency. But when we want to do the proficiency-based training, we need to do the assessment, and metrics comes in place for it. As much as the assessment may sound simple, but it's actually for the trainer a complex cognitive task. We need to observe, record, interpret, evaluate, and effectively give a feedback to the trainee. And a good assessment, it's not only about the trainer, but it's also about the assessment process that we do have, the assessment tools that we use, and it's also about the trainee to be informed, to be engaged. So if we want to do a good assessment, we need to put all of this together. We do have different ways of doing assessments, so looking into the assessment tools. We have that conventional assessment tools like goals, gears, OSATs, we know all of them. It's of course resource intensive. You need an expert to look into the training and perform that. And although OSAT goes for the objective assessment, but we all know that this is still subjective. For example, a concept like careful handling of tissue, for me, that I'm a pancreas surgeon, careful handling of pancreas is way different than careful handling of appendix or the gallbladder. So it still stays, the subjectivity stays, even though we are putting it in a numeric scale. So in contrast to that, or adjunct to that, we do have the proficiency-based scoring system, which is a binary scoring system, doesn't have subjectivity, and there we try as much as we can take out this subjectivity from that. And of course, we are hoping to have automated and AI-based metrics, which if we develop it in a good way, there should be a less resource intensive. You don't need a human expert to look at the performance, and it can be, of course, very helpful if we do have a good one. So let's see what we can do and what is possible with AI for surgical education. If you look at the surgical education, I would say AI-based assessment means that using AI as that binary assessment tool, it will be considered as an easy task for AI to do, while AI-based training stays as a very difficult task. What is AI-based assessment and what we can do? This is actually the basic skill anastomosis task, the very first task that we train the novice robotic surgeon on it. And you may probably know this scoring system. This is a proficiency-based system developed by ORSI Academy. We have divided this to 5 steps. There is a granular definition of the suturing operative error, knot tying errors, as well as critical errors. And this is actually how we assess those performance. And you maybe the font is very small to understand what is written, but as you can see, there is a very binary yes and no granular way of assessment of that skill. But of course, if we want to do this assessment, which nowadays is still at ORSI Academy, we do it this way, it means that every trainee that is doing this procedure, a trained trainer watching continuously and has to evaluate in that way. Otherwise, it will not work. Of course, at ORSI Academy, we want to make this work more affordable from the human resource, and we are spending a lot of time to research to see how we can automate that. This is actually an algorithm that we have developed that can perfectly segment all the elements in the picture, as well as instrument that we have, and we can accurately calculate the total distance travel and average instrument velocity. This is, of course, something that also a lot of robotic companies provide us this information, but we cannot get that for research purposes. But we have developed our own algorithm, which works perfectly, and we want to see if we can use that for surgical training or not. We also have developed algorithms that can detect those binary yes and no with the AI, and you can see, for example, needle out of view is one of those errors that should not happen, and here AI system can see that and recognize that. This is another example, for example, an incomplete or repeated bite, if you look at it, and these are also the tasks that AI can help us to recognize. So the computer can look at the performance and we can see that there is an incomplete or repeated task. But let's see what that means in terms of proficiency. This is a study, actually it's under revision, has not been published yet, but we call it the motion illusion. Why is that? And because we looked into the simulated anastomosis task of more than 100 videos of the novice trainees in a real world life data, people who are coming to ORSI to be trained, from being a novice, totally novice to the robotic platform, to becoming proficient in this specific task that I just showed you. And using our self-made algorithm, we have calculated the velocity and the total distance travels. This is the data that we have looked into. So we basically divided the performance, regardless of the surgeon who has performed, to the binary way of proficient versus non-proficient. And guess what? Comparing the proficients versus non-proficients, we don't see any difference, any significant difference between the total travel distance and the velocity of the performance of the proficiency versus non-proficiency. Of course, it's disappointing, but we looked into the subgroup analysis of this as what we call it within subject comparison. We compared the specific surgeon from being novice to becoming proficient. And there, actually, we see an improvement in velocity. And why is that? Because we tend to put those benchmark numbers, and we always talk about it, to benchmark against the expert performance. But actually, if we only look into the economy of the motion, that's not an accurate way of doing it. And why is that? Because my proficiency, my speed and velocity is different from your proficiency, speed and velocity. And the parameter that we should look into is not that if I can operate at your speed or not, but it's I can operate at your quality or not. And that's the question that we need to answer. And that's where AI-based training comes in place. And for doing that, we need to not only be calculating all those numbers that we name as a parameter for surgical training, but we also need to be able to interpret those, and we have to be able to give that back as a feedback. And I won't go to a lot of details on how we are going to do it, because there is a lot technology development has to be done in that system. But probably one important point would be the vision language models that we do have. And I think if you have followed the presentation and the discussion of my colleague Walter Buchhardt yesterday about Montix, which was the clinical presentation of what we can do with the vision language models in the operating room, probably this will be the solution also to improve the surgical training in future. And how we do, hope to do that is that to be able to feed the system not only with the endoscopy view of the surgical performance, but also with the data of how we give feedback, what are existing in the profile of the patient, or at this moment the simulation task we are doing, and with all of that basically make a holistic view of the training ecosystem that is happening. So just to conclude about talk about surgical AI, where are we and where we should go, I would say that surgical expertise cannot be reduced to motion metrics. We should forget that with calculating the time, with calculating the velocity and the travel distance, we can differentiate. I saw already this morning studies showing that we can differentiate expert versus non-expert in that. We can follow our training paths by looking at the speed that we operate, by looking at the velocity that we operate on it. But again, this is not alone as a standalone a good metrics for surgical skill assessment. I think still at the time, the validated PBP training methodology remains as a gold standard of calculation of the surgical training proficiency. And I think if we want to use AI as an adjunct to our surgical training, we need to move from measurement to interpretation and to understanding of what is happening. And the contextual learning, I think, would be the missing point there. And I hope in future we integrate AI with the validated PBP methodology, so we make computer systems that are able of recognizing that proficiency that we hope in the surgical skill. We need to shift from tracking motion to contextual understanding, and we need to probably leverage the vision language models for procedural understanding, real-time feedback, and for cognitive skill assessment. And in a simple language, we need to develop AI system that can tell what the surgeon is doing, why are they doing it, and is it appropriate to do it that way? And that's how we look at the AI development. Are we going to do that? It's a very difficult thing to do, but as of today, we are still working on this to make this a reality. Thank you so much for your attention, and I think we will do the questions in the end.
Thank you, Niki. Very, very interesting presentation. I have some questions, but I think we can do a discussion at the end together with Daniele Amparore, that I kindly invite to reach us here on the stage for his presentation on potential role of the human digital twin in precision surgical planning.
Thank you, Federico. Thank you to the Vattikuti Foundation for this kind invitation. It's a pleasure to be here to discuss a little bit about the role of human digital twins in the precision surgical planning. I will talk about this topic, but I want to start saying that preoperative planning today is considered a sort of mantra of the precision surgery path. But the problem is that standard imaging tools nowadays could be not sufficient to enable an adequate planning to allow a precision surgery plan. So this is the room in which cutting-edge technologies comes into play, because they give us new perspective, new eyes beyond the standard. They stimulate us to consider new scenarios, new paths, new ideas, favoring intellect, favoring reasoning, and imagination development. So the idea today is to discuss about these cutting-edge technologies with this perspective, and specifically to discuss about the role of the evolutional role of 3D models that nowadays can be considered, started to be considered a new tool, a new digital tool, so the new digital twins. And to discuss about this this path, this evolution, this constant evolution, I want to identify three different times. The past, in which 3D models have been developed, the present, so what we are facing now, discussing about these incoming technological tools that is represented by digital twins, and what will happen in the next future, so the integration of these digital twins together with AI systems. Starting from the past, around 15 years ago, we started to see the representation of the anatomical representation of the organs different from a simple rendering coming from CT scans. They were built by bioengineers step by step, considering each structure composing an organ of interest or a target organ. The process was quite complex, because we started with the acquisition of DICOM images that were then segmented and post-processed by the bioengineers manually, and then in order to obtain an interactive 3D virtual model that gave us an amount of information, a not negligible amount of information, because we can have perception of the morphology of the organ, but also of the boundaries of each structure composing the organ. With the use of a 3D navigable PDF, it was possible to vary the transparency of each structure composing the organ, so to study also the hidden anatomy, the hidden portion of the organ, the central portion of the organ, for example, for the kidney, the structures inside the renal sinus, such as the collecting system or the vessels, but also to visualize the pathological target, for example, the tumor, and studying the relationship that it can have with the surrounding tissues. The first step towards the concept, probably towards the concept of digital twin, it was made by the implementation of an algorithm able to represent the perfusion volumes within the organ. Not only for the kidney, but also, for example, for the liver. We had some studies demonstrating the possibility to represent each vascular area depending on the distribution of the vascular tree, information that were functional, so added something new to the standard morphological evaluation of the organ. But moving from the past to the present, we have to try to face with the concept of digital twin first. What digital twins means, and what is today in our field of work and our field of research. A digital twin is considered a virtual model that represents a real-world entity, and it can predict also its behavior over time. The concept was originated by NASA for aerospace simulation in 2010. And integrate different technologies together, Internet of Things, but also AI, machine learning, data analytics, and is applied in many fields of application, including also healthcare, every day more also in healthcare. In the setting of surgery, digital twin means a dynamic virtual replica of the patient anatomy. So, first of all, a tailored representation of the patient anatomy, integrating different multimodal data coming from different data sets, so data set coming from imaging, but also clinical parameters, but also perioperative informations that are put all together in order to recreate a replica of the real organ. The goal, the aim to develop such kind of technology is to improve the planning, but also to allow the simulation and also the intraoperative guidance, the intraoperative assistance during our surgical procedures. And can be integrated with AI, but all the examples already published in which AI integrates together with the concept of digital twin in the field of surgery are still limited up to now. If we consider urology, that is my field of research, the main field of research, the digital twin is considered an evolution of a 3D virtual model in which we consider not only the anatomy, but we try to integrate information coming from other than morphological data, so coming from different data sets, as I said, also for surgery. That means imaging, but also clinical information. So the first attempt to evolve a 3D virtual model towards the concept of a digital twin was to integrate other features, other characteristics, such as, for example, the texture of the organ or the elasticity of the organ. We are working with soft tissues, so we have to try to find a way to simulate also the deformation of the organs. The idea was the rationale was to maximize the grade of concordance between what we see virtually and what we have in the operative field at the time of the surgery, so a concordance of the virtual organ with the real one. And to develop this idea of digital twin, first we started considering how to apply a specific texture, a real texture over our 3D model. The idea was to build first a 3D phantom composed by independent virtual elements, to select independently some textures coming from the intraoperative images, and then fuse together these two technological tools in order to assign each geometry modulating the zoom, the rotation, and the sides, and the orientation of the texture over the 3D phantom. The final result was an evolution of 3D virtual models in which it's possible to appreciate also the texture, the real texture, or similar to the real one of the organ, but with some anatomical details, some additional details given by the 3D virtual model. For example, the representation of the vascular areas, the vascular regions, and the perfusion volumes of the kidney, which were the fields of application of this first attempt of evolution of 3D models towards digital twin, both planning but also intraoperative guidance, because the surgical planning can be assisted by such kind of digital twins, maybe in an immersive environment such as the one of the metaverse, in which people can interact together in form of avatars and discuss about the clinical case and the planning strategy, having the virtual tool just in front of their virtual eyes, but also the assistance during the surgery, performing a cognitive guidance during the robotic procedure, because these virtual tools can be put within a digital device, such as the screen of the Prof, for example, but also a tablet or a personal computer, in order to assist the surgeon at every step of the surgery. And the clinical clinical study we did, trying to understand the usefulness of such technological tool, demonstrated advantages, especially for novice surgeons, in identifying some anatomical structure that were not clearly visible by the naked eye. For example, the identification of the pedicle of the kidney, but also the tumor, but also structures that have to be spared, such as the ureter at the time of the dissection. But if we move from the present to the next future, we have to understand that digital twins needs to integrate with AI in order to evolve over time and become a real, face with the real concept of a digital twin, so an evolution over time. And this is possible. I will show you some examples of what researchers are trying to do in this direction. The first idea is to apply some AI systems, machine learning systems, in order to automatically select the proper texture for each structure of the organs that we are trying to reconstruct in the form of a digital twin, leveraging some convolutional neural network strategies, but also other researchers are working directly on the translation of the grayscale of the CT scan into real colored organ with AI softwares in order to skip the intermediate passage of having of doing a 3D reconstruction and applying a texture over it. Second example is about the studies focused on the understanding of the real organ elasticity. Some studies, preliminary studies, were focused on determining the manual deformation of the organs exerted by the robotic arms. But nowadays, other studies are working on developing machine learning softwares in order to understand the elasticity and the deformation of the organs in vivo and quantify the tool-tissue interaction. And then we have the new kid on the block that is represented by the integration of other imaging informations to our 3D reconstruction. I want to explain you the example of prostate cancer, in which we are trying to integrate information coming from different sequences, new sequences of MRI, such as the STIR sequences. We already discussed yesterday about this new technology in order to reproduce at least some fragments of the fiber nerves of the nerves surrounding the prostate, so the neurovascular bundle, in order to recreate a sort of skeleton of the neural network surrounding the prostate. This is possible thanks to the integration of an AI software that works like a navigator, so leveraging the same strategies, so the iterative skeletonization and the cost-based pathfinding, in order to understand which is the most likely path of the nerves where the MRI is not able to see the presence of the nerves itself, and with whom it's possible to have a complete reconstruction of the nerves, of the anatomy of the nerves surrounding the organ. With this system, it's possible to improve the quality of our 3D digital twin for the planning. As you can see, the texture is improved, but also it's possible to have information about the structures surrounding the organ, not only the nerves, but also the veins and also the arteries, in order to manage at its best the dissection of the neurovascular bundle during the surgery, and that we can also follow at the time of the surgery in an augmented reality setting, overlapping not only the structure surrounding the prostate as represented yesterday, like just a part of nerves, vessels, and vessels together, but representing each nerve in the proper position in order to tailor at its best the nerve sparing approach. Also for the kidney, innovations in terms of digital twin, because we integrated radiomic analysis in order to evaluate the internal characteristics of the tumors, of the renal masses, considering morphology, heterogeneity, and enhancement patterns of the tumors, and putting together this information also with the clinical variables and the morphological aspects of the tumors, in order to establish a specific score aggressiveness of the tumor itself, to maximize the efficacy of our planning, but also to tailor the decision making of our procedure. As you can see, we can represent, we can score which is the probability of the tumor to be aggressive or not, and integrating these informations together with the other anatomical information we have coming directly from the calculation of, for example, nephrometric scores, but also the perical management strategy or the resection strategy or the suture technique strategy, we can maximize at its best our planning also in the setting of partial nephrectomy. So to conclude here, my take-home messages, first of all, patient-specific data and advanced imaging are redefining completely the surgical planning of our urological robotic procedures. Digital twins are becoming one of the new tools in the surgical, available in the surgical armamentarium, enhancing not only the evaluation before surgery, but also the assistance during the surgical procedure. And the future steps will be a further integration of human and machine in order to maximize at its best the planning, and combining data and technology together to maximize the planning, but also to improve at its best the decision making of our surgical procedures. Thank you.
Thank you, Daniele, for your presentation. I will start the discussion with a question for Niki. How long is the typical training on site through the program at ORSI, and do you think AI will shorten this?
Thank you so much for the question. The training, well, we do have a basic skill training and procedural training. Basic skill is basically basic task for training, skin dissection, vessel dissection, and depend on the specialty. For example, for general surgery is bowel anastomosis, for urology is simulating vesico-urethral anastomosis, and for gynecology is vaginal cuff closure. And this makes a program for basic skill training. We do train to proficiency, and of course it's not time-based, so I can tell you that typically it takes for most of people 2 days to pass, but sometimes also to 3 days, so depending on the skill and how fast the person would learn. And we hope more looking into AI help us as a trainer to offload a bit of a faculty development. But as of helping the trainees, I think for robotic surgery, virtual reality development, which is also part of the AI development, has helped a lot, because in open and laparoscopic surgery, we were very much obsessed as a surgeon with the haptic feedback. Robotic has completely removed that, and virtual reality simulators are a great help in training and can reduce the time needed for practicing.
Okay, thank you. Professor van der Poel, do you have a question for our speakers?
Yes, I do. Thank you. I'm pleasantly surprised, Niki, by your observation that kinematic data are lagging behind. They're not giving us the information. I thought I was the only one struggling with that. But so I sense that you're going to look at basically tissue sensing, and I wonder how you're going to do that. And may the option of the force feedback in the DV5 be helpful there?
Absolutely. That's actually a great point, that when we are looking to the computer vision, there is also data out there, not a lot, but there are some studies showing that the performance, how you handle the tissue in the computer vision point of view can predict the outcome. And that can be something that we can use as a surrogate for the surgical performance. And I hope that probably most of you have tried the Da Vinci 5, the feedback that you get. even in terms of what we need as a surgeon, I would say is very premature. So it's not really something that we can use, but maybe the data that we can get out of it could be something that shows the force feedback on the tissue, and that's also something that we need to keep to account. But I think we all, as probably the generation who were lucky to learn open laparoscopy and robotic surgery in a longitudinal way, have learned to move from the haptic feedback to the eye feedback. And we get more of that information from watching at it. And we hope that with computer vision also we can reach that. So whatever the human does, we hope that the computer can replicate it. So to answer your question, I think we more have to focus on what we are seeing other than what we are feeling, because robot has changed that concept.
Fully agree. Thank you.
Thank you.
So first of all, congratulations, fantastic presentation, both Niki and Daniele. So yesterday and today I heard several times a vision language model, which are basically generative AI. In 2026, many people are talking a lot about agentic AI, but I haven't heard the expression physical AI in this meeting. So basically, physical AI means that you can reconstruct a virtual scene from videos rather than images. And after seeing your presentation, Niki, about training in robotic surgery, and of course, as you know, you can use even virtual reality simulation for training surgery, and the presentation of Daniele on 3D reconstructions. Do you see a role of physical AI in both surgical planning and virtual reality training?
Good question, difficult question. I think that probably there is a major role in training that in the planning phase, because in the planning phase we have just to we can have just informations coming from imaging or from the patient, so clinical data or lab analysis. And we have to figure how to face with the surgery, which is the best surgical strategy, for example, which is the best for the patient, also in terms of indication, not necessarily from a surgical perspective, but maybe from in terms of indication, the patient has to be operated or not, for example. So I think, Niki, tell me what you think about, but I think this kind of technology is more useful in the training phase, because you take informations coming from, for example, videos, intraoperative videos, for example, and leverage the information content within these videos to develop something new after the surgery.
I think I agree with you that in general, I think whatever we can use from AI, it doesn't, I don't mean to simplify training, but I want to magnify the impact of what we are doing on the patient. When we are doing a real surgery, what we are doing is way more complex and actually more important than what we are doing in the skill lab for training. And also, when you are thinking about giving guidance to somebody who is already an expert surgeon, the quality of guidance should be way higher than giving a guidance to somebody who is a novice and wants to become just learning a specific skill. So keeping this concept in mind is intuitive to think whatever AI can do, probably the first step would be in training, then going to the intraoperative guidance for the surgeons. And we have to first validate it in the training setting before we want to use it in the human setting. So an answer to your question, definitely, I think there is a possibility for using this in surgical education. And I think in surgery, the first thing that AI can change, I hope, is education.
So thank you so much.
Thank you.
Yeah, wonderful talks, both of you, and I think it is a corollary to the previous question that if we talk about a procedure planning, and for a person who has been doing that procedure, and you showed all the ways we can integrate the CT scan and other images. So have you been able to develop a model which is integrated into a robotic platform, and a person can do a surgery before the actual surgery, looking at the vascular anatomy, and even so that helps even a kind of expert or a surgeon early in the learning curve in procedural planning?
Sure. Every different information can be obeyed in preparing the surgery, in setting the best planning. So I think that in the next future we will try to add more information coming from different fields. So, for example, molecular imaging can be a field of application, a field of interest for the integration of the information content within the images we can obtain from molecular imaging, in order to improve the amount of information we have within our digital twin model, in order to maximize at its best the planning. The problem is that when you try to put together all this information, you have to find the best way, maybe AI-driven, to make the integration itself. The problem is that, for example, we are trying to develop a software able to represent the elasticity of the soft tissues, but this software maybe is not able to dialogue with the other AI software that integrate informations about, for example, the aggressiveness of the tumor, or about the vasculature of the kidney. So find a way to integrate all these algorithms, all these AI systems together will be the next, probably the next challenge we have to face with.
Great, thank you so much.
Okay, so we are running out a little bit of time, so I think we can close this session. Once again, I would like to thank Niki and Daniele for their nice presentation, and the audience for the discussion. Thank you.
Thank you.